Hi everyone, this is kind of VK Prasad Lab video. It's not the VK Prasad Lab is no longer active for now, but it's really in the mood of the VK Prasad Lab. And many members are here. Alison is here, Sunny is here, Christopher, Dries joined us. And today it's our great pleasure to have Ade Adamson. So Ade Adamson is a associate professor in the Department of Internal Medicine at Dale Medical School at the University of Texas at Austin. He has a really broad interest in derm, melanoma, over diagnosis, over treatment, epidemiology in general, also research on disparity. Maybe you will explain us more about that, Ade. So it's really our great honor, and we invited you to talk about a recent paper you published with your colleagues. And maybe before we start, Ade, could you tell us a bit more about you, your background, how you became interested in epidemiology, in these topics that you will be talking about, just briefly, so we know also how you came to be interested in those topics.
Yeah, so I'm a dermatologist who is obsessed with understanding more about screening and is it useful or not. Obviously, you can understand how that's important in my field. We do a lot of screening of skin cancers. And so the quote epidemic of melanoma, which has affected also young people as well, as I guess it's been my thing for a few years to study. We've published on this before. And I guess I would say that is kind of the beginning of the story of why this particular question is of interest to me. But in the talk that I'm going to give, I'll explain like what actually led up to it and the people involved to get the paper out and published.
Great, great. I just want to mention to listeners and to watchers, this paper this work you published in 2021, it's a New England Journal paper. It's for rapid rise in cutaneous melanoma, and really encourage people to read this paper, which is really fantastic because you're explaining with the pathology view, with the oncologist view, with the epidemiologic viewpoint. And to me, it's really a seminal paper because it can really be applied to many, many other fields. And I think you will apply some of the tools of this paper also in this topic of the early rise of onset cancers.
100%. And I appreciate those kind words, by the way.
Yeah, I mean, the stage is yours. And so after your presentation, we will be probably asking some questions and trying to get some more understanding.
All right, so before I launch into this brief talk, I want to acknowledge my co-authors. First, Vishal Patel. So Dr. Patel is a surgery resident at Brigham and Women's Hospital, and he's probably one of the most talented trainees and mentees that I've ever had the pleasure of working with. And I anticipate him doing a lot of great work in this space in the near future. And then I'd also like to acknowledge Dr. Gilbert Welsh, who was a mentor of mine and longstanding collaborator. And I guess it goes without saying that this area of work, he has in many ways been one of the leaders in it. All right, so let's first start with level setting here. And what is early onset cancer? Early onset cancer refers to the diagnosis of cancer in individuals younger than 50 years of age. And 50 is an arbitrary cutoff, basically kind of just that aligns with traditional age-based screening guidelines that we have, like around colorectal cancer screening, et cetera. And I also want to make a few points about the importance of early onset cancer, lest anyone think that I don't think it's something serious. It is really serious because people that get diagnosed with cancer have more life years that are potentially lost. They often aren't candidates for cancer screening, and so they may present with later stage symptomatic disease. There are other issues related to long-term toxicity, fertility, pregnancy, et cetera, the psychosocial impacts, career disruptions. Young people often have young families and children to care for, or even parents to care for. There's also the financial toxicity. People that are younger often don't have as much of a nest egg yet, and a cancer diagnosis can be really serious from a financial standpoint. And also, there's just system strain, right? People that are younger have a lot more complex services like freezing your eggs or the long-term follow-up care that you need after getting a diagnosis of cancer. So early onset cancer is bad, okay, and it should be taken seriously. And I would say that this is also important because
Oh, you can share again your screen, maybe.
uh,
Yeah,
you see it?
yeah.
That's good. Okay. Most people that see this video also probably have come into contact with headlines like these. Kate Middleton being diagnosed with cancer. There's a whole feature in Time magazine, the race to explain why more people are getting cancer. CNN, New York Times, Washington Post. It's everywhere. There's also funding agencies that are getting into the game as well. So you got the NCI. You have CPRIT, which is the funding agency for cancer in the state of Texas. They have an entire RFA related to early onset cancer research. Cancer Research UK is also getting into the game as well, funding millions and millions of dollars for early onset cancer. There is even a special session, a special conference on the rise of early onset cancer that's going to happen next month. 4 days. And the U.S. Preventive Services Task Force guidelines have even shifted to lower ages, in part in response to the rise of early onset cancer here in breast as well as colorectal. There's been a surge in research on early onset cancer as well. Okay, so hopefully I've convinced you that this has been, outlined as a really important problem to a lot of people. But unfortunately, a lot of the focus has been on incidence only. Okay, whether it's here in this JAMA Network open paper or in pancreatic cancer in this JAMA research letter. In fact, it was this research letter that got the eye of Vishal, right, the first author on our rapid on our paper that's the focus of today's talk. And what he noticed was that there was no discussion about mortality in this age group. And when he crunched the numbers, this is what he found in this paper that we eventually published. Mortality was flat, right? Despite a doubling of pancreatic incidence, especially in young women,
So
mortality was flat. This is, yes.
Can we ask questions throughout the talk, or?
If you want.
Yeah, I mean, that's very interesting. Just if you can explain. So what you did here is you looked at incidence and mortality throughout decades and looked the evolution over time, right?
Yeah. And what you would expect is for a potentially lethal cancer like pancreatic cancer, among the most lethal cancers that we diagnose, with rising incidence, you would expect mortality to also rise in tandem as well. But that didn't happen. And when that happens, it is concerning for what we call overdiagnosis, or the diagnosis of disease that would not have progressed to death. And it's not like with this diagnosis, there was no response. In fact, if you looked at whether patients got surgery or not, pancreatic surgery doubled in women and men in this population here, right? So these folks were being intervened on, right? And again, if this actually was leading to some outcome that was curative, you'd expect mortality to go down, right? You're catching more, you'd expect mortality then to go down. We looked further, and what we found is, increase was almost entirely in early stage disease, right? So it's an 8-fold increase in early stage disease in women and 3 in men. And then most of that surge was in endocrine and pseudopapillary forms of pancreatic cancer. Those tend to be a lot more indolent, right? And they aren't the majority of lethal carcinomas of the pancreas. It's the adenocarcinoma subtype that is the most lethal. And this eventually was picked up by the New York Times. And essentially what we showed is that the increase in incidence of pancreatic cancer in young Americans is basically from detection of small early stage endocrine cancers and not pancreatic adenocarcinoma. And so after doing this paper, we asked the question, well, what about other early onset cancers, not just cancers of the pancreas? And so what we set out to do is to look at the fastest growing cancers in people under the age of 50, okay? Meaning those that had an at least 1% per year annual rise. 8 cancers fit that bill. And we just asked the simple question, what about mortality in these cancers combined? And what we showed, again, another classic signature of overdiagnosis, right? Incidence doubled, mortality flat, even metastatic incidence. So people that present with late stage disease, flat. You would think that this would go down with this much rise in incidence, or at the very least, that mortality would also go up in tandem, but it did not. And actually, if you break it out, right, by cancers, because obviously there's some heterogeneity here among each cancer. Each cancer has its own unique story. A couple of things stand out. One is, if you look at the y-axis here, see deaths? It is a lot less common than, incidence, right? You got to zoom all the way in to even see some of these trends. And while most deaths from these cancers have either stayed flat or gone down, 2 have actually gone up slightly, colorectal and endometrial. So some of this is in fact real. So what explains the patterns for each of these cancers? For thyroid cancer, it's largely overdiagnosis. For anal cancers, it's changing patterns of HIV and HPV that explain its rise and fall. If you look here, where it rises and then it falls again. Then there's kidney cancer, it's largely overdiagnosis. Small intestine, it's overdiagnosis of indolent neuroendocrine tumors. And in colorectal cancer, it's some of that increase is real, but some is also due to neuroendocrine tumors or appendix, tumors of the appendix now being lumped together in colorectal cancer, in colorectal cancer incidence. And for endometrial cancer, it's rising obesity and probably decreasing rates of hysterectomy, right? Because now there are more people with intact uteruses to now then develop cancer. And as we showed earlier, pancreatic cancer is mostly from overdiagnosis. And some of you on the call that are actual oncologists probably understand issues related to overdiagnosis and more lab testing for patients with myeloma. But there's also, some good news here, right? While there's been a lot of excess diagnoses in cancers like thyroid cancer, so here what we've done is basically we calculated the excess incidence, meaning the amount of diagnoses above the 1992 threshold that have been diagnosed in excess, right, over the last 20, 30 years. And as you can see, there's a lot of excess diagnoses in these cancers, right? But there's also a lot less death as well for myeloma. Melanoma, excuse me. But this is all treatment. Breast cancer, this is all treatment. And over here, lung cancer, both deaths and diagnoses have gone down because less people smoke, right? Non-Hodgkin lymphoma, both down because we've done a better job of treating and managing HIV and its complications. But it is quite tremendous in these, cancers here, how much excess diagnoses in the young population there does exist. But we also have to keep in mind that overall, early onset cancer mortality has fallen tremendously. And that gets lost in this narrative while we're scaring the hell out of the population. And now, whenever I talk to people about this topic, they raise a couple of questions. One is like, what about treatment improvements? Mortality, it's flat because we're just better at treating. And what I would say to that is that treatment advances would have to perfectly counterbalance one another year over year, right? So not too fast, where mortality would fall, but not too slow, where mortality would rise. And again, that is implausible. Okay. Well, what about treatment improvements in cancers where mortality is declining, like melanoma and kidney? Sure, perhaps, but that then raises the uncomfortable question of, then why is all of the incidence increase in these cancers confined to early stage disease, right? And then, there's also, well, you're just showing cancers that are before 50 years old. Those cancers would have then manifested later at 50 to 54. And I got a slide for you here. That hasn't caused any difference, right? If we were actually catching them under 50, these then wouldn't also be going up as well. It's part of so that does not explain it. Okay. And I think this is important beyond cancer, right? Because we have this obsession now, especially on social media, around finding cancer early through full body scans, right? Most famously, Kim Kardashian, right, with her millions and millions of followers, suggesting that people just get preventive MRIs for disease, right? And she's doing this saying it's not an ad, right? You probably got to pay her millions of dollars to, post something, right? And Prenuvo's getting free, basically a free ad here. And, unfortunately, I don't know if you saw this in the news last week, but as a result of these scans, they have found what I'm assuming is an asymptomatic aneurysm in her head. And again, she's going to be showing this on an upcoming episode of Keeping Up with the Kardashians as a result of the prenatal scan. And then the downstream effects of then having to get follow-up testing, follow-up brain scans at Cedars-Sinai. So this is a really, really important problem, and hopefully we can discuss on the rest of the call.
Great. Thank you, Ade. That was really nice. I have some questions, but I want the audience to start. Who wants to start? So maybe I start. Okay. Ade, yeah, I think it's really nice. You really nicely put in context this topic of early onset and rise in early onset cancers. Maybe can you explain again more, because I think there is a common misunderstanding between crude rate, or the global burden, the crude rate of patients with cancer, and the relative increase. I was really struck by this paper. I think this paper also led to this phenomenon you described. It was a BMG paper, and they showed that the global burden of cancer over 3 decades increased by 80%. And of course, this was crude numbers. If you take relative numbers, it was 3%. Can you explain that again with your words? And also, you are very good at that, because I think it's really important to have this difference in mind for people exposed to these numbers, which are very scary. When you say 80%, you're scared, obviously.
Yeah, and so cancer statistics sometimes can be really confusing. And sure, there are more diagnoses of, X disease or X cancer over time in a population that is growing and changing, right? Obviously, the numbers are going to go up, But when you present numbers in a population, you want to have that age standardized, right? And present it as a rate, usually per 100,000, right? So that you can really make sense of that number over time, right? Because it keeps in mind the changing just growth in a society, as well as the distribution of ages in a society, right? And so you have to present numbers like that. And that's the numbers that we were presenting in our paper.
Yeah. And there's another comment I want to do is the psychological aspect of this, because and again I agree with you, having cancer as a young person, or and we know some people having that, and we take this seriously, and it's not the case to downplay that. But as doctors also, by the mere fact of practicing, you will be exposed to something which is rare, which is cancers of young people. And so there is a kind of psychological aspect, even if the frequency is perfectly stable, even if you assume that, by the mere fact that it's emotionally high, it's a really high, even for the doctor, you may have the impression it's increasing. And at the end of the day, it's not really increasing. And even when you show the numbers, when the mortality is increasing for colorectal, it's a small number. It's not a number. I don't think it's a number that you
It's
can.
not an epidemic.
I don't think you can really feel that as a doctor. And maybe you. I mean, I doubt you can really feel that in your practice. So, I think there's a psychological aspect on that. I don't know if you want to comment.
Yeah, it's like I said in the outset, it's as a young person, prime of their lives, middle of their careers, kids, and then if you're a physician that's also of similar age, to them, or you can remember, how old you were when you were at their stage. It really, and it's tough, right? And there are also people that um, because they're in the prime of their lives, it's just more just emotionally, I don't know, seemingly serious. Like, of course, old people get cancer. It's a disease of older people. But when a young person gets it, it feels particularly tragic.
Yeah. And the last comment, and then I promise I will stop. The last comment is, why I feel it's so important to publish this kind of work is also to try to focus on really the things that seems to matter more. I mean, when you're showing that, I think there is maybe a signal, maybe, I mean, this is there, in colorectal, endometrial.
Mhm.
And so, it's also, you talk about funding, but how do you see that also in terms of priority? If we are focusing on a full topic with a lot of funding, which at the end of the day, it's maybe more colorectal, more another tumor type, maybe there are some missing opportunity. So what is your comment on that?
Yeah, so I have a lot of comments on that. Um, I think what happens is you get an entire conference related to early onset, cancers, when it's more of a mirage than anything else. You got, people coming together, flying in, spending tons of money, grant agencies spending millions of dollars on something that is mostly an artifact of us looking harder for disease and not actual something biologically the matter. So we're going to throw all this money looking for a biological cause when more likely than not, it's just that we're looking harder,
Yeah.
right? And then where it gets really frustrating is then what happens is then, you have epidemiologists and, other scientists dredging, data sets, making correlations between, whatever your exposure of the day is,
Yeah.
Tylenol, a fruit or, some, other drug and, your risk of early onset cancer. And then, that gets into the media and then everybody's, scared again.
Yeah.
Right. And it just creates this cycle when the cause for the rise in early onset cancer is in plain sight. It's us. It's medical care.
Yeah. So I have another question, but I keep it for later if nobody will ask it. Please go, Grace. Yeah.
So I think a lot of things have to do for me with terminology or how we define these cancers. If I just, for me, I look at my own field, prostate cancer, for example, we have very low risk prostate cancer. We have high risk prostate cancer. A lot of people that are 50, 55 get a diagnosis of a low risk prostate cancer, Gleason 6, but we still define it as a cancer. And that still scares people, but it's our role for me as a doctor to tell the patient that, well, we phrase it as cancer, but it won't behave as a cancer. And I think, especially in the lay press, if you cut out all of this fear making, let's call it like that, you get a totally different vision. You have totally different numbers. So the terminology, for me, it's really important. So what defines a cancer? What doesn't define a cancer? And we have to take care as a general community of doctors to communicate it very well to the patients, so that they're not scared anymore, to decrease the psychological burden of a potential cancer.
Yeah. And, I would say this is also hard because as physicians, we're treating a patient and not a population. What I've described, is just, population data. But when you're sitting there and, a patient had I don't know, a Prenuvo scan and they found some small, like incidentaloma on their kidney, and then they biopsy it and, oof, this looks like it might be a, early cancer. What are you going to do? I mean, the horse is already out of the barn. You also got to do something, right? And it's tough, right? And then what ends up happening is then people think the solution to this problem is more screening, more scans, and that only just perpetuates the cycle. And that gets perpetuated by the lay press a lot, as well as some of our fellow physicians. And I think to the peril of, the population.
I also agree with this cycle where things reinforce each other. In breast cancer, there's, like dense breast tissue, family history is important component. So people sometimes start MRI screening and in addition to mammograms, and then they end up getting like a early cancer seen on MRI that's not seen on a mammogram. And then they're like, for the next 40 years, they're obsessed about how their breast cancer isn't seen on mammograms and is getting constant screening and finding very early cancers or pre-cancers. Yeah, I had a question about the term overdiagnosis. So it seems to imply that it can be avoided. But like pancreatic cancer or kidney cancer doesn't really have screening programs, and they're, I think, kind of just incidentally found because there's more access to advanced imaging. And again, like if a woman gets breast cancer, she usually gets a breast MRI for better staging and scan the pancreas they found in your endocrine tumor. Do you think it's avoidable when you say overdiagnosis, or it's just happening, we recognize it and just say it's not a endemic episode of early cancer? How would you frame that?
Yeah, it's a difficult concept for I think even physicians to grapple with, let alone the lay public. But I think that it's just going to be a problem that's going to continue and become even more of an issue with advanced imaging and easier access, as you state. And I think artificial intelligence is going to supercharge it, because all artificial intelligence is doing is just recapitulating the very diagnoses that we're overdiagnosing, that they're learning the data sets on which they're learning. So that is my fear. And if we don't have a more open conversation with patients and the public about this issue, I think it may get more out of hand.
Yeah, and Sunny, do you want to add something? No. Yeah, this was one comment of mine. I don't know. I mean, it's going in what you are saying now. But my worry is also, all this communication. I worry that in 10 years, we will maybe even see a peak, a 2023 or 2025 peak, just because we are communicating so much that people will also be doing more tests, more labs. And so I think it can increase just because of this very scary in communication. And yeah.
100%. The media is in part responsible for creating some of this fear that that I think is driving some people maybe to get imaging.
Yeah. Any other question, Alison, Chris? Or any last?
I'm wondering
please go.
because one of the things that was talked about during the pandemic was that people were not able to go and get their routine screening because there's prioritization around treating patients. I wonder, I don't know the answer to this, but if the question is whether there is overdiagnosis, is whether in the absence of that routine screening period, what implications that has and what things and how that may support or go against like some of the data. I don't know if you've thought about that at all.
Yeah. So if you look at some of the work in this space, basically what they've shown is that mortality rates basically, kept on their same trajectory, whereas incidence rates had, blips. And this is like across just about every single, cancer. And one of the, I guess, I don't know if it's fortunate or unfortunate, but one of the things that happened during the pandemic that to me was somewhat surprising is that, yeah, some screening did cease, but it came back online pretty quickly after everything shut down. It wasn't like people refused screening for, 2 years, right? Maybe it was for, a few months, 6 months, something like that. And once screening rates, went back, not all the way to, pre-pandemic, but, approaching that, incidence rates, jumped up again. So if you look at the SEER numbers, there's the 2020, blip, and then, back up for multiple different cancers. And for melanoma specifically, I can say that definitely happened.
Yeah. Alison, last question.
Yeah. So, okay, I know that overdiagnosis has been a topic of even like all ages, so not just under 50. But I guess my question is you talked about like the indolent, some of the tumor types within that general tumor cancer, some of them are more indolent cancers, especially in the younger ages. Has that been looked at in the older age? And so do trends in younger ages mirror what's happening in older ages, or do they have different tumor types within like, like pancreatic, different subtypes?
Yeah. So it depends on the cancer. Each cancer, and its subtypes are different. For I could say that the problem is once we've diagnosed a cancer, we don't know which ones are necessarily going to be indolent versus ones that are going to progress. So you end up treating, all of them. And that is a particular problem for, I think, just about any cancer. Who wants to sit and wait and do nothing when they're told they have, pancreas cancer or a melanoma, or, a kidney cancer? So well, sorry if I didn't completely answer your question, but go ahead.
I want to go further into that. We do have this treatment regime, not so treatment, it's just active surveillance. For urology, we have it in prostate, and we use it a lot, actually. And if you frame it good and a well-informed way to the patient, they most of the time go along with it. And we also have it in kidney. So with all these kidneys, abdomen scans, and we find small lesions on the kidney, most of the time we will say we wait a little bit, we do some active surveillance for this, and this will be, I think, for all the tumor types that you discussed. It's really important to implement this kind of, well, not treatment, but just surveillance programs.
That's one way out for sure. And I would say that the urologists are probably the most advanced in that kind of work. I could say for melanoma, we're definitely not there, at least in the dermatology community, for a lot of different reasons. So that's a great point.
Ade, I have a question also related to what Dries said. So a very important thing is to communicate, as you are doing in this paper and today. I think this is key to raise awareness and advance this question. But would you see any concrete implementation? I don't know, health in terms of health policy, or I know this is a very challenging topic because, of course, also this is giving works to doctors. So I mean, this is also part of the problem. I mean, this is fueling an entire system. So what are your thoughts about that? And do you think of any policy about that would tackle this problem?
That is $1 million question, and I don't know if anyone is fully being able to answer that. Is it? And I don't know. Is even talking about overdiagnosis enough and getting enough people listening going to do anything? I don't know. I don't know the answer to that.
We hope, but we don't.
But we hope. But you're also, like you said, forcing doctors to talk more about uncertainty with patients. That takes a lot of time.
Yeah.
And you're not necessarily rewarded for doing that.
Absolutely.
Right. And so I'm trying to imagine a scenario where you say, all right, you got a tumor in your pancreas, but we're gonna like sit and wait and watch and see what happens. I don't know, short of doing a trial, which I think they're actually doing for pancreas cancer, looking at active surveillance. I think maybe that's a way out, but you got to do that for just about every individual cancer.
I think raising awareness is important, but I agree with you. We are not sure it's really impactful. I mean, globally. But I want to thank you for doing this research and this also to communicate so clearly those research findings. I think that's very helpful. I don't know if anyone has further comments or questions, because we are lucky to have you, so we want to take advantage, but we don't want to spend too much time as well. Last thoughts, comments? Anybody? So thanks again, Ade. That was really great. And I will say, like Vinay said, on that positive note, but maybe if you have a last comment just to conclude, what would you say, or what would you recommend, or what are your last thoughts?
Whenever somebody tells you that the incidence of something is going up a lot, ask about the outcomes of interest, like mortality, especially as it relates to cancer.
Great words. Great words. Thank you very much, Ade, and see you soon, everyone. Stay tuned.